Hello friends, welcome to the Learning Channel, a platform dedicated to the learning of laparoscopy, endoscopy, artificial intelligence and robotic surgery. Welcome to this step-by-step guide on diagnostic upper gastrointestinal endoscopy, also known as esophagogastroduodenoscopy or EGD. This essential procedure allows direct visualization of the esophagus, stomach, and duodenum to diagnose and treat a wide range of upper GI conditions. The procedure begins with patient counseling and obtaining informed consent. The patient should fast for at least 6 hours to ensure an empty stomach. The patient is positioned in the left lateral decubitus position. Local pharyngeal anesthesia is administered using xylocaine spray. Conscious sedation may also be used, typically with midazolam or propofol, based on protocol. The endoscope is gently introduced through the mouth and advanced under direct vision into the oral cavity. Here you will see an inverted image with the tongue seen in the upper part and palate in the lower part of image. As you advance the scope, you will see two midline structures which indicate you are in the midline. First structure is the uvula, which is seen at 6 o'clock position, and beyond it is the upper free edge of the epiglottis. Now angulate the scope downwards and go below the epiglottis to see the laryngeal inlet. Right and left piriform fossa can be seen on either side of the larynx. Gently advance the scope across the upper esophageal sphincter from either left or right side of the midline to enter the cervical esophagus. This should be done with extreme care and no unnecessary force should be applied while doing this, as it can lead to bleed or even perforation at this site. Now, start insufflation to open up the lumen of esophagus. Advance the scope keeping it in the center of the esophageal lumen. Normal luminal indentation is seen at 25 cm caused by the left bronchus and arch of aorta. At around 38 to 40 cm, you will be approaching the GE junction, which is marked by the upper end of gastric folds. The squamo-columnar mucosal junction is represented by the Z line. Cross the GE junction to enter the stomach. Insufflate to open up the gastric lumen. The scope is maintained in the center of lumen and advanced under vision. The direction of angulation and advancement should be forwards, gently going towards right, and then slight up angulation in the distal stomach to see the pylorus. Gently negotiate the pylorus to enter into the first part of the duodenum. First part of duodenum, also known as the duodenal bulb, is a small space, and continues into second part of duodenum beyond the superior duodenal angle, which is seen as a blind turn at D1-D2 junction. Negotiate the D1-D2 junction to enter the second part of duodenum. This is indicated by presence of circular duodenal folds and long lumen of D2. Papilla may occasionally be seen, especially if prominent, on the medial wall of second part of duodenum. After examining the second part of duodenum, withdraw the scope gently to go back to the stomach, and position the scope in front of the pylorus. Now, insufflate the stomach, then start doing upangulation of scope to see the incisura angularis. Do complete 180 degrees upangulation of scope. At this point you can see the proximal stomach and the endoscope. Maintaining the upangulation, withdraw the scope gradually to approach the cardia and fundus of stomach. Do insufflation to open the lumen of stomach while approaching the cardia. Do a complete 360-degree examination of cardia and then examine the gastric fundus. After examining the cardia and gastric fundus, then let go of the upangulation and bring the scope to straight position. Now gradually start withdrawing the scope out. It is a good idea to suction out the air in the stomach, and also any significant amount of fluid if present in the stomach. This completes the diagnostic upper GI endoscopy. Thank you for watching the video.